This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection web-based education series. And I'm also thanking you for taking time from your busy holiday season for this very special presentation entitled A Win-Win Approach to Comfortable Anesthesia, Adapting Your Clinical Skills for Success Using C-Clad Technology, which will be defined momentarily. Comfortable and successful local anesthesia is a hallmark of successful dental treatment, the foundation for building patient relationships and referrals. Successful clinicians strive to provide the most comfortable treatment possible, investing countless hours in developing their anesthesia skills. The adoption of computer-controlled local anesthesia delivery technology, or C-Clad, for pain management communicates to patients that yours is a leading-edge practice focused on patient comfort, which also benefits both the clinician and team member. Kathy Bassett, BSDH, RDH, and Masters of Education, has administered local anesthesia as an expanded functions dental hygienist for more than 35 years. She is professor, educator, clinician, consultant, author, and presenter, delivering hundreds of courses on local anesthesia. This course presents the mechanism as well as advantages of C-Clad from both the patient and clinician perspective. Manual and wand syringes will be contrasted side by side, and tips for effective transfer of injection skills from manual to wand syringes will be presented. Whether you are currently a wand device user, are new to the wand, or are considering investing in one for your practice, this presentation will prove invaluable. I want to remind you that Practice Perfection webcasts run for around 90 minutes. While attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we do not get to your question during the webcast, we'll see that they're answered shortly thereafter. Because this presentation is being recorded and you will receive a link to the recording, please do not feel the need to take copious notes. Just sit back, relax, and enjoy Kathy's presentation. Attendance does entitle you to receive 1.5 hours of continuing education credit. Shortly following the webcast, you will be emailed a brief survey with instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practice if the course has not provided them with adequate clinical experience to allow them to perform it competently. And now it is my sincere pleasure to welcome to the Practice Perfection stage, Ms. Kathy Bassett. Hello, Kathy.
Hello, Danny. Thank you so much, and thank you to all who've joined us. I hope that this presentation will leave you with a few holiday treats to take back to your office. And first, I'd like to say that C-Clads have changed the way I approach local anesthesia and the nature of pain experiences for patients. For many patients, the perception of pain is what keeps them away from the dentist and may drive many canceled appointments. A common ground for dentistry is that most patients, the mere sight of a manual syringe evokes some degree of anxiety. As a colleague of mine put it recently, if the holy grail of comfortable anesthetic is going slow and taking our time, how can anyone dispute that a microprocessor regulated syringe is more controlled, predictable, and comfortable than relying on free-handed methods that we've all grown up with in dentistry? Also, I believe there's an unappreciated factor for us as clinicians in the advantages of C-Clads. One of the most important sustainable assets in any dental practice is our ergonomic health. And C-Clads can eliminate repetitive motions that can injure our hands, thumbs, and wrists. I've had many discussions with clinicians who are actively using C-Clads, and some who became interested in the technology, got a device in the office, had some successes, and then had some difficulties that discouraged them. There is a learning curve to merging your traditional approach to local anesthesia with a C-Clad device and the techniques, but I strongly believe that the effort is well worth it for both the patient and for us as clinicians. And so the game plan this evening is to really share highlights of my 10 years of working with C-Clads. I want to leave you with some tips that can maximize moving to the next step with C-Clads. Identify some factors that transferring them from manual syringes to C-Clads can be some of the stones we need to step on, and muscle memory is a big one. And then I want to really encourage you to connect well-honed injection skills and techniques you've already acquired to C-Clad technology and really integrate them in for a comprehensive approach to local anesthesia using the computer-controlled devices. So a little bit of history, benefits, and being that we're in North America, there's a few real specifics for us. C-Clads have been available since 1996. They're clearly a proven alternative to manual administration of local anesthetics, and there is a wealth of information and a broad body of research internationally speaking to both comfort and reduction of injection traumas and just patients' perceptions that really drive this. And the heart of the whole thing is that C-Clads use electromechanical motors to regulate microprocessors to precisely control fluid dynamics. They're just little computers sitting there maintaining a system that adapts very well to the physiology of pain for our patients. Benefits from that then become we have a reliable flow rates. We're not starting, stopping, pulsing. Controlled fluid pressures because of those reliable flow rates. Those both go on to decrease inflammatory responses for any microtraumas, specifically at the site of injection. That goes on to increase patients' comfort. Also, because of that microprocessor control, we have accurate and reliable aspiration tests in the midst of our injections. And there's some ergonomic advantages for clinicians that I believe most people haven't even really considered. So I definitely want to highlight those as we go. In North America, my first experience was actually with a comfort control syringe. And my father practiced dentistry for 47 years. And the last 5, he said the 2 things he didn't like to do anymore were extract teeth, because it made his hand hurt, and aspirate during an injection because of arthritis in his thumb. So he bought a comfort control syringe, and of course I had to go play with him. And then from there I went on to have opportunity to experience the original wand device, the Compudent, the wand STA system, and now it's marketed as the wand STA computer-assisted anesthesia system with DPS, which is dynamic pressure sensing technology. And the reason I'm so specific in naming that device is it is in fact the only C-Clad device we have available to us in North America. So it really drives what we are going to do as far as C-Clads. Here's kind of another piece of where my history come from. Is about 6 years ago, I had a couple of students come to me and said, yeah, we'd like to do a research project, and we've been reading about this computer-controlled delivery, and we want to know more about it. So they put together a study, and these are the first participants, and one of the most striking things about this group of dental hygiene students is they each elected to purchase this device themselves. So the pilot group, in fact, all own their own devices and left going into practice with their own devices. For us, a lot of excitement came around that. So here are the questions that we asked. So over the last 6 years, we've been looking at what drives people to adopt new technologies. And one of the things that keeps coming up is clinicians will tend to lean towards that which they're most familiar with. So if I am very comfortable using my manual syringe, it's very easy for me to convince myself that I can do all the same things that a C-Clad device can do. So what we did with this is we took half the students who from day one learned all of their injection techniques with manual syringes, the other class learned all their techniques with C-Clad devices, and we had them stay with that for 6 months. At the end of 6 months, we've crossed them over, and our 6th group of students will just be doing that crossover this coming January. And along the way, we have surveyed them before and after each patient experience and each clinician experience. And we're asking questions about how confident they felt in their ability to utilize the device they had, and their confidence in that clinician that was going to be given an injection to them, how easy they were to use, and how comfortable they were. And later I'll tell you how that came out. And not only did they initiate this project, they actually won a national award for it. So our very first year out of the gate, we set a national precedent on this study, and again, we've continued it into 6 years. So here's kind of the heart of the matter. When we look at discomfort during injections, there is that piece that's about the initial penetration of the needle. But then the next thing that happens is experiences that are generated because of the pressures of the anesthetic solution coming out of the needles. Depending on where that injection is and the nature of those tissues, there are pressures that build up in that space. And this is from research that was done by the original developers of this device, in particular Dr. Mark Hochman and Dr. Mark Fredman. And this information has been pulled together, and it also is the basis for the dynamic pressure sensing technology that's in the current C-Clad. So we look at the adaptive capacity of the tissues, whether we're doing infiltrations in buccal mucosa, if you're doing an inferior alveolar block where you're in that retromolar fossa or pterygomandibular space. And the difference in the nature of that tissue versus the attached gingiva and palatal tissues, if we're doing, say, a papillary infiltration, or we're doing a nasopalatine injection, greater palatine injection, the AMSA injection. And then how do all those same dynamics function if we're actually in periodontal ligaments? And it's quite a different injection giving a periodontal ligament injection with a C-Clad device versus with a manual ratcheted device that's been designed for those types of injections. So first off, slow rate. The slower we administer the anesthetic, it will drip from the needle tip, and the more drip-like the flow, less pressure in the tissues, and more enhanced comfort for the patient. As soon as we increase that rate, excuse me here for a moment, when we increase the rate of delivery, there's actually a bursting phenomena that happens right at the needle tip. And this was some research that was done in 2005. And they found that patients can actually perceive that first increase of rate when we're giving injections, and that it actually exceeds pain thresholds for most of the patients in the study. So if we can take that information and overlay it on the controls of the C-Clad devices, you can see a pattern of where this controlling flow, which therefore controls pressure, results in a decreased pain experience. So the first image is just what it looks like when we first start out. So if I am using the wand device and I first push on the pedal, for the first few seconds, this is what I get, just a drip, drip. Then as I increase the flow rate, then I get a little burst at the beginning, and then just a gentle stream from the syringe. And then if I push the pedal all the way down into the fastest rate available, I truly get a streaming out of that solution. And each of those will increase in pressure at the needle tip as that flow rate increases. What most of us were taught initially in school was that an appropriate rate of delivery was approximately 1 milliliter of solution per minute. And that's when we get that initial little bursting, but a fairly soft stream of anesthetic. When we increase that rate to approximately greater than 2 milliliters per minute, that's equal to emptying one entire cartridge in 1 minute or less. Then we increase that pressure to the streaming, which has been demonstrated to be clearly perceivable to patients. The next factor after rate is the needle gauge itself, and that has direct impact on the pressures exerted at the needle tips. So smaller gauge needles, like 25s and 27s, will generate lower fluid pressures at the needle tips when you compare that to a 30 gauge needle. And for me, that's like playing in the backyard with the hose and the water's just coming out pretty gently versus putting your finger over the end of it or your thumb over the end of it to get that spray out of it. And when we close down that lumen, we significantly increase the pressure as the fluid exits. Now we look at that lower fluid pressure, and we know that those are associated with reduced post-injection pain and edema. And every needle penetration generates a small trauma. Every time we express solution, there are traumas that are exhibited within the tissues. So the goal is to control the flow, lower the fluid pressure, reducing the injection traumas, and then ultimately ending up with a more comfortable injection and less post-injection pain. What's kind of fascinating to me is for how many years clinicians will purchase 30 gauge needles and believe they're doing so because they believe a 30 gauge needle gives a more comfortable injection. However, all of the science and fluid dynamics shows just the opposite, that we use a 30 gauge needle, we use 2 minute per cartridge, 1 minute per less than 1 minute per cartridge delivery rates, and we're significantly increasing the pressure at the tissue site. So just a disclaimer before I go on more specifically here. The wand is the only device sold in North America. So I am strictly talking about the wand STA device. I'm not affiliated with the manufacturer. So the information I'm going over is what we've learned, tips that will help you move more quickly through your adaptation to it. It's still important to read the manuals, be fully familiar with everything that comes with your device. So this is not a manufacturer's training, but if you're considering the wand, you've just got one and you want to jumpstart a little bit, or you've had some experience and need to be encouraged to get back to it, I hope that some of these things will be useful to you. So 4 things to talk about. Armamentarium, that'll be the drive unit, the syringes themselves, and different ways to manage aspects of that. A few things on technique specific that are built into the design of the device and the outcomes that we have. My kind of favorite topic is the ergonomic piece, and then I'm just going to kind of point you in some directions of what you might be able to utilize next to move you along. So when you very first get the unit, one of the first decisions is, where do I want to put it? So we're going to talk about that. You hold the wand for the first time in your hand, and it will clearly not be the syringe you're used to, and kind of have to figure out how you're going to work with that. And then what is all the information I get from the lights and the tones and the voices that come out of the base itself? And we have a few tips about acclimating to those. So I'm going to cover 8 items in particular on the drive unit. And the first is, let's just do a little tour. So the first thing that we have is we have the cartridge volume, or the cartridge volume indicators. So this is going to tell me how much solution is left. And it takes a little bit of a learning curve to understand what they're telling you. And I'm going to go into that more specifically in a couple minutes. STA mode, think of that as your periodontal ligament mode. So if we're doing single tooth anesthesia, we're going to be utilizing periodontal ligament injections, and this is the setting that slows it down to about 0.005 milliliters per second. the slowest rate that's controlled by this device. The next is the DPS light system that shows the progression. So if I'm in the right site for my periodontal ligament injection, I will get that auditory and light visual feedback letting me know that the appropriate volume, solution, and pressure in the tissues is being generated. I can select my flow rate. So there's, in addition to the STA mode, there's a normal mode, which is going to be about 1 milliliter per minute, and then a turbo mode. Interestingly enough, I've heard people make the presumption that the wand automatically does the aspiration for you. That's not correct. You need to select aspiration mode, and then you will activate the aspiration process, but then you're going to have a lot of reliable controls with that aspiration. There is a mode up here for retracting the piston that's going to press that plunger and dispel the solution. And I want to talk a little bit about the piston. And then there's a multi-cartridge mode, and we'll talk about that. Select trainer. This is where you can actually elect to have a voice walking you through particular aspects of the device versus having tones. So when you first start, it's really helpful to have a voice telling you aspirating, or having a voice telling you that your pressure is building when you're doing a PDL injection. And then later,
Kathy?
Yes.
I'd just like to ask a question at this point.
Yes.
Do you have any feedback, suggestions, or experience on how the patient might react to hearing that, or does the system offer like an earpiece so that only the assistant is hearing the machine? Because I could envision where a patient might get a little nervous, not understanding that, or thinking, oh God, you know, you need to be trained on how to do this. Do you know what you're doing?
Excellent question, excellent observation, because I have my own personal experience with that. When you see item number 10, it's speaker volume. So let me pop through 2 more, and then I'll be at the volume conversation.
Great.
There's a turbo mode, and this is just my personal thing. If we know that the faster the rate, the more comfortable the injection, just my personal thing is I wouldn't ever use turbo. So it's, you know, it's in red because I would encourage you to just stick with normal mode and STA mode. And then speaker volume. Sometimes when you first get to using this, if you've been in an emergency ER and heard all the tones when you're hooked up to monitors, it can remind you of that. So Danny, I appreciate that question. For some
and
patients,
I've been there before. That might be part what informed my question. Because, I was in surgery a couple of years ago, and I was astounded at how it was almost like they thought they were working on a crash test dummy, like or unconscious patient. They were talking up a storm and really expressing concern and confusion about things. And I actually set up and said, excuse me, folks, I'm still conscious. You really want me to be hearing all this?
Yes. Well, the thing with our volume here, we can actually turn that down. So you will either get a voice with some tones, or you'll get just some tones. And depending on where you put it, then as long as one of you can hear the signals you're getting, but you can adjust that volume. But if you turn it off, you're going to lose some of the signals that you get. So you have to kind of work with the individual patient and maybe show them so they see the information, and you can let them know, this is letting me know how much anesthetic I've delivered. And for most of the cases, that seems to help our patients move through that.
Yeah, that's a good approach, to just let them know that, you know, you can always spin things, you know, either negative, positive, or neutral. And if you say, well, this is, the purpose of this is to make sure that we administer anesthesia in the most effective, efficient, and painless manner, and so you're going to hear some prompts, and I just wanted you to prepare that for it. That helps me ensure that I'm delivering anesthesia as effectively as possible.
And most of us, if we've worked with cell phones or worked with your computers, you're used to your cell phone giving you a signal that you've got email. So when you analogize it to that technology that's around them all the time, they seem to get it, that this is just another communication method of technology.
Very good.
But yeah, absolutely. I know exactly what you mean on that, so thank you again. Drive unit placement. Try and put it line of sight first time you're using it. When you can start calibrating what you hear with what's actually happening on that panel, I believe that you acclimate to that more quickly and you'll be more comfortable actually having it out of line of sight more quickly. What tends to happen initially if you have it behind you is you'll tend to turn to look at it because you're wanting to see, you know, what that tone meant or what's going on, rather than keeping your eyes on whether you're holding your position with your injection. So there's definitely a value to line of sight placement. This seems like something, you know, pretty little, but it really can help your day. These bags are tough, so it's great when they're, you know, being stored in different areas. I'm never worried that a bag's going to be torn or damaged, but that also makes it kind of hard to tear them open. So we just take scissors and, you know, cut open the bag or two that we need for that appointment, so we can just easily slip that wand out of the bag and get going. The next thing that can be helpful when you're first setting it up is the tubing can be a little bit stiff and hold its coil when it's been in that bag. So what I was taught to do is actually just take it and tug it. And as you pull on it, it softens. And if you do that with the full length of your cord, then by the time you put it in the device, it's not tugging back on you. A lot like when we went from, you know, coiled to straight tubing on our handpieces on the dental unit. And so in this image here, you can actually see there's that long, straight, soft tube draping, which again won't have as much pull right at the wand itself. Loading cartridges, occasionally you'll first get started on this and you'll push down on the foot pedal and you're ready to deposit your solution and you're going, there's no solution coming out. Make sure that when this is seated that all the lights come on the fluid indicator levels. That's what's going to tell you that you're seated in there. And I'm sort of, you know, surprised how many times we'll be in the middle of watching an injection and kind of going, nothing's happening. And we all look at the base and find out that, you know, these lights have not come up. And again, make sure that it just seats down, good clockwise turn, and the lights will be your indicator. It's not going to click or anything. So just getting it right in that slot. On the cartridge volume, it's a little bit opposite of what you're used to. If you're right-handed, you're used to perceiving fluid leaving the syringe from right to left. Left-handed clinician, you're pushing on the plunger, you're aware of solution disappearing from left to right. On the wand, when it's in the cartridge slot, it's going to be expelled from bottom up, but the light indicators are going to go from top down. And you'll see that it'll say full. You'll have 5 lights on when a cartridge is full. But when I first step on that pedal and I'm starting to administer the first quarter of that cartridge, that full light goes off. So this doesn't mean that I've given a quarter of a cartridge. It means I've started and I'm in that first quarter of the volume. And so when I get to 1/4, that means I have, when the 1/4 light goes out, it means I have 1/4 of that cartridge left. Then when empty light goes off, now I've expelled all the solution. Otherwise, when you first start, you kind of feel like you're about a quarter of a cartridge volume behind. Again, putting in the cartridges, give them a good firm push, and there's a plastic spike. And we found that on occasion, the cartridges just didn't seat well. So as the manufacturer's brochure will talk about is, you know, pushing and turning. And if it doesn't go down, just pick up another cartridge. Give it a try with something else. Occasionally we've gone through 2 or 3 and just had to realize that there really wasn't anything wrong. It just happened to be, you know, the situation for that pairing of the cartridge spike and the cartridge. And usually we've, you know, been able to get through that without having to change to another wand. Here's what it'll look like if you're not seated. It'll just keep bouncing up and down on the little spike, but you'll definitely see a portion of your gray stopper extending beyond. Don't try and load it in this way. It'll actually put too much force on the piston, and it may actually break and then dump solution into the device because there's too much force on there when the piston then tries to come up. Multi-cartridge functions, one of the sweetest things on this machine. I really like this. If you're doing an injection where you normally would plan for 2 cartridges or more of anesthetic in a particular site, particularly with oral surgery cases, people who are difficult, to achieve anesthesia. You can come to your deposition site, administer your first cartridge, have your assistant dislodge the cartridge, change out, put a fresh cartridge in, and you remain at your injection site the entire time. You don't need to withdraw. So that reduces microtraumas at the site, reduces the potential for another positive aspiration, for any small muscle injury, trismus, just reduces any of those cumulative penetration risks. When you're used to just having all that control in your hand, sometimes changing to the foot pedal will become your biggest learning curve. And this is interesting when we watch the students. When they don't have any experience, the fact that they would control it with the foot pedal didn't seem to throw them because they hadn't controlled anything before. When we switch over, those that started on manual syringes had a harder time acclimating to the foot pedal than those who started with the wands and moved to the manual syringe. And that paradigm has repeated itself each year of our study, that the folks who start in C-Clads are much more adaptive to both techniques than the folks who started on manual syringes. They tended to have a little tougher time acclimating in the other direction. So foot pedal just attaches to the front, and it has multiple levels to click. So that's another thing that's important to practice before you have your first patient in the chair. Otherwise, it's like when you're first learning to drive a clutch. You kind of lunge forward, you lean back, and you have a little bit of that start-stop experience. So definitely spend some time with your device, watching the lights, and getting a feel for the pedal when you are in that drip mode, when you're in that normal flow mode. There's a cruise control, so once you have started your flow, it'll set the rate, and you don't have to maintain pressure on the pedal any longer. It will complete that injection delivery on its own. Piston maintenance, you have to periodically just do some very simple maintenance on the device. It's built in to the microprocessor, so it's going to tell you when it's time to change its O-rings, and it would be really nice to be like your car, telling you, hey, it's time to change my oil. In the process of this, it's important to not damage the piston itself. So here, we take the cartridge out and remove it, and then you're going to see me reach around behind the machine and actually power it off. Now, while the power's off, I'm going to push the hold for the piston, and then I turned the power back on, and that extended the piston. At this point, you just want to be careful not to put too much pressure, trying to get that O-ring off, because if you get that piston off at an angle, it's going to cause you some problems along the way. So just pay attention to that vertical piston. Now moving to the syringe itself, and this is just called the wand. So from here on out, I'll just refer to it as the wand. Manual syringes, they really have a substantial weight to them when you compare them to this very feather-light plastic wand. They have unregulated injection pressures. They have unregulated aspiration pressures. And for many patients, we're all aware that they can elicit a psychological reaction. In contrast, the wands are very light. They're less than, actually that should be 0.4 ounces. They are extremely lightweight. The microprocessor will control the injection pressure. It will control the pressure of the aspiration for consistent aspiration. And this little plastic tube has very minimal psychological stimulus for patients. In this picture, it's actually my hand on the bottom in both of these pictures, and so I have a very small hand. So you can see, for me to hold a standard syringe, I have to really extend and open my palm. You can actually see the tension along the bottom of my hand by my little finger. In contrast to someone who has a fairly large hand, so this would be a size small glove, contrasted to a hand in a size large glove. they still have to have a fair amount of extension of the thumb to balance the syringe and a lot of opening. So we consistently will have a flexion and extension going on in the muscles of the hand to balance, manipulate, and express solution. Contrasted with the wand, all you do is pick it up and hold it. So if you have something sitting next to you right now, just a pen, a pencil, just pick it up and hold it in your hand, and that is how you will hold the wand. The wands come in a variety of styles, and I just want to really quickly contrast them to manual syringe needles. First off, all manual syringe needles will have a sharp needle puncture end. So every time we take off a cap, we're going to have that safety factor there and a potential sharp. Standard gauges, this is what we find most used in North America for the kinds of needles on manual syringes. On the wand, they have bonded needles, and they will come in 3 sizes that equate to what we are used to as a long, short, and extra short. And you're going to find that they come in, and actually this 27 gauge, 1 inch, this should actually say 30 gauge. And then a needleless universal wand. So 27 long, 30 short, 30 extra short, and then a wand with no needle. The wands with no needles, then you can go to a third-party supplier and actually purchase Lure Lock needles. The advantage of this is you can choose a needle type that might be a little bit different than you prefer. And also, it allows me to use 1 wand per appointment. So let's say I know I'm going to give a posterior superior alveolar, and I want to use a short needle. And I know I want to give inferior alveolar, and I want to use a long needle. I can get 1 wand and then just change out my 2 needles rather than opening 2 packages. And for us in particular, when we're working with periodontal therapies and we're doing multiple injections for quadrant therapies, not having to have multiple wands was a real advantage for us. The bonded needles, they're required when you're using the DPS technology on the wand. So the seal is going to help maintain the pressure in there and not have any minor air leaks that might cause an irregularity in that. Where the wands, when they screw in, again, I can change them out 1 wand, multiple needles. If I'm doing the STA mode, PDL injections, I want to rely on that DPS, I'm going to stay with the bonded needles. The base has recapping capacity built right into it, and they just have little rubber gaskets that hold my needles. And here's a pair of Lure Locks with a universal. So these become sort of a dual purpose. First, they are my needle recappers, but then during the appointment, when I'm ready to switch, I just reach back, unscrew it from one side, screw it onto my other needle, and I'm ready to go. So it's a very easy switch between needles, more so than with manual syringes. The next thing I think is actually easier with the wand is confirming a positive aspiration. Because it's clear all the way, I actually have a quicker detection if I do have a positive aspiration. I will see that blood trickle literally in the hub area, and then as it progresses, I will see it actually pull up into the tube itself. And this is a much quicker realization if I'm in an area with a positive aspiration. Again, reminding everybody you need to set that and select aspiration mode. And I just say pick it when you first get the machine and then just don't ever take it off. It's way better to always have it on than have to forget it and be in a situation where you've got to stop your process. And again, the aspiration is controlled by a single press on that foot pedal in the midst of your injection. And you can re-aspirate periodically whenever it seems appropriate to you. So my next group of things is let's touch on some things that I think are helpful when you are transferring to techniques that are really designed to benefit the presence of the C-Clad. Learning curve is really important, and just know that you're going to have to work through some of these things, and it's just going to take practice the same way developing the techniques you use now took practice. Adapting them to the C-Clad technology takes practice, but from my perception and the perceptions of the students I've been working with, we all think it's really worth it. So if you've got that pen or pencil handy again, go ahead and just pick it up and just hold it very lightly in your hand. That's what your first experience is going to be, just picking up this very light object. And in fact, for many of you, a pen that you might have picked up is very likely going to be heavier than that wand is. With manual syringes, we always have the distance of a cartridge. The needle's always a cartridge length away from where our hand is. When we have the wand, it's really easy to just pick it up and bring our fingers right down to the hub. So with different injections, depending on how far away your site is and how deep you need to go, you're going to have to do a little bit of adjusting so that you start back for some injections when your instinct is to come right up close. And my brothers would say, don't choke up on the bat. Give yourself a little bit of distance here. So for an IA injection, I'm going to position my hand back here. If I'm doing an infiltration, then I'm going to be closer up to the hub in that situation. And the wand really is designed to be an all-injection device. And for me, when I have the conversation about single-tooth anesthesia, that's just maximizing periodontal ligament injections. And we, in fact, teach every injection that our students learn, and that includes Gaugates injections, using the wand. We don't distinguish that there are techniques that are only for the wand. We use them universally for everything, and in particularly we find them most useful when we're doing periodontal ligament injections and palatal injections. Another little cool thing about the wand is I'd like to see any of you try this with a manual syringe, is we can modify these down, and this is what I kind of call, moving towards the stealth technique. There's a little slot in here so you can peel that rubber tubing down, and then you just bend the wand back and forth. It's a very flexible plastic, and you can break it off at various lengths. So when I'm actually approaching the patient, this is the only portion I have. So it almost looks more like I'm just coming with this little soft tube, and particularly with a short or extra short needle, the needle's barely perceivable approaching your patient.
That's a really powerful benefit, which I hadn't considered, Kathy, which is just, it's the expectation, the suspense, the dread that a needle presents. And so when you don't really have to even show that, the cascade effect never even commences.
Exactly. Completely eliminate that initial cue. And if you can visualize it, imagine that you brought this, down low, so you're coming up past the patient's chin. There's nothing that comes into their line of sight. Even with injections that are traditionally, we would have some portion of the syringe visible. The next thing is the bi-rotational pen roll technique, and this is in fact unique and specific to the wands. And most of, I'm assuming everybody at some time has learned this concept, but if not, I'll just walk it through really quickly. When we give an injection with a standard syringe, the deeper the penetration, the needle will tend to deflect away from where the bevel is facing. So if I'm doing an inferior alveolar block and the bevel's facing towards the ramus, the needle's going to actually be deflecting medially, making a wider gap between where I actually want to put the anesthetic and where the needle tip is. And on all beveled needles, on all manual syringes, because of the girth of the syringe, we can't do this self-correcting motion, because these wands are so lightweight, you just literally put it between your fingertips and you roll it. And what it does is it self-corrects as you approach. So here's on our little rubber head guy. And just watch how in my fingers I roll this between 90 to 180 degrees back and forth. I proceed on a straight line, no arcing, which would actually bend and wave the needle within tissue. And we just continue that rolling motion. And we've done some little visual things, and we do this in bars of Neutrogena soap where you can see the pathway. And we can have as much as a 20 degrees or greater deflection on beveled needles versus needles that we're doing the bi-rotation on. So it definitely gets you closer to your deposition site.
Whereas the bi-rotational needle has what kind of a deviation? You said 20 degree on the...
Relatively none. Relatively none.
Zero.
In our trials, they were less than 5 degrees.
And the Neutrogena is like that transparent or translucent soap, transparent, so you can actually see the line. Is that?
You can exactly. You can see your needle track, and it really brings it home what's happening to a straight insertion versus this bi-rotation.
Very cool.
This is my favorite practice partner. When you are learning to really make friends with your wand, get yourself a big bag of cheap oranges. Just sit down, hook up the device, and just practice the rotation. Practice with the foot pedal. Get used to the volume flows, the starts, the stops, because this patient's not going to, look at you like, what are you doing? And they're not going to feel like you've turned them into a guinea pig. So I just really can't say enough for oranges when it comes to getting a handle on the different components of tones, voices, lights, and manipulating the syringe differently than you're used to with your manual. And again, the trainer mode will coach you through. It's going to identify verbally when different aspects of the process have occurred. This is where the STA really got its name, and its intention was for maximizing single-tooth anesthesia. Single-tooth anesthesia is utilizing periodontal ligament injections in a way that you can really focus on one tooth without so much collateral. Soft tissue anesthesia makes it easier to do teeth in opposite quadrants or opposite arches, and there are just numerous benefits to doing single tooth anesthesia. People who've used manual ratcheted periodontal ligament syringes, generally the intention is a rescue injection. We're in the middle of a restorative procedure. There's that one spot that just is not numb, and this allows us to keep right on going within a minute versus having to go back and do a whole nother cartridge repeated injection. And it really takes advantage of the porosity of the spongy cancellous bone for the drug to quite literally flow into that dental plexus. So here, just in cross section, you can really see that airiness. Our periodontal ligament space is going to be just right adjacent to the tooth. In a manual periodontal ligament technique, you would literally were told to wedge the needle tip against the bone. In this one, we're going to just have you insert gently and just stop when you have resistance. There's no need to forcibly wedge into that crestal bone space. And then what we're going to do is you're just going to start the flow, and this is going to take a little longer. Traditional technique is you're going to take approximately 20 seconds per site. With this technique, we could very easily take a minute or 2 or 3 to do the whole tooth. Single-rooted teeth, we're going to pick 2 sites. Multi-rooted teeth, you may do up to 3 sites. What's going to happen is that drug is going to utilize the periodontal ligament space to flow into the spongy areas, and then it's going to send almost like a back pressure signal. So as adequate volume has flowed into the space, the pressure can be perceived at the needle tip, and then we're going to start having the DPS indicator lights start to light up. So as that pressure builds, they'll transition across the device, and when we get to the green, that tells you you're in a good position, and in fact you're getting that flow of drug into the space, and the syringe is able to pick up that pressure. So really think in terms of an accumulation creating the pressure versus us forcibly exerting pressure on the drug to get it in. And it can be up to 1,200 pounds per square inch when we use manual devices. Just demonstrating here, picking 2 or 3 sites. Most certainly pick one buccal and one lingual. And when you're looking at the lights, sometimes they don't light up all the way. So always clinically, blanching is going to be your #1 clinical sign that you have got adequate drug delivered around that tooth. So even when the lights don't go up, if you've got the blanching pattern, you've achieved what you need clinically. One of the other things that I learned is that this became frustrating for some clinicians, and I think it was that they just weren't getting adequate angulation and were possibly blocking the needle with soft tissue. So when you first start, I highly recommend taking a periodontal probe and walking around to the sites you think you're going to select and really visualize with that probe what the best approach is, and that's going to really help you, I think, get proper angulation more reliably. And this is why I think hygienists do very well with this, because they have such an affinity for probing. So when we're in STA modes, our 3 friends are going to be the cartridge volume indicator, and we're going to use half a cartridge for this injection. We're going to watch the lights for the progression, but if I don't come all up to the green, I've got blanching around the tooth, I'm going to consider that a successful injection. And then again, we want to make sure that we've selected that STA mode. That's going to keep it down to that very slow drip, drip flow rate, and then have adequate pressure to get it into the space. I just want to throw this technique in while I'm on periodontal ligament injections. We just refer to this as a rescue injection, but if you have a block that didn't take, rather than going back and doing an entirely second cartridge, you can come in and do PDL injections on the second molar, and because of the proximity to the inferior alveolar canal of the roots of that second molar, very frequently you can resolve that block with one PDL rather than taking the dam off, having to completely stop your procedure. And Dr. DeMarco, who's one of the co-authors on our textbook with us, he and I have been exploring with these for a number of years, and he's the one who brought it to my attention, and we have found this to work very reliably, but it needs to be the second molar where you're closest to that nerve. And then again, we're going to use a half a cartridge, at least 2 sites. The AMSA injection is one of the ones that is written up in the instructions when you buy your wand device. And if you haven't used this before, I highly encourage you to explore this and really see what it can do for you. It has some real benefits in doing quadrant anesthesia, particularly for periodontal procedures, and it initially was designed for aesthetic procedures. And I don't have time this evening to play the whole clip, but there are 2 episodes of Chairside Live with Dr. Michael Detola where I was a guest, and so we on camera went through all the steps of an AMSA injection with a wand, and we went through all the steps of a Gaugates injection using a wand. Here's the episode that you can look up for the AMSA, and it's this is Chairside Live, episode 81, and just to give you just a little taste of it. So, and literally, we'll walk you through the injection from start to finish. You'll be able to see the whole blanching pattern, and then a short conversation with the patient that this was demonstrated on, who herself is a dentist. Here's what a successful AMSA looks like. We did the penetration at the junction of the vertical aspect of the alveolar process and the horizontal aspect of the palate is our site. and we are administering between 1/2 and 1 full cartridge. In this case, we used lidocaine, 2%, 1 to 100,000 epinephrine. And what happens is because the tissue is adhered to underlying bone, it uses kind of a trampoline-like effect, and it just holds the drug in there, and it's able to diffuse into that spongy bone. It will literally diffuse all the way through. So here, our penetration site in the photo on the right is right where my mouse is circling. Here's looking from the occlusal incisal view, and you can see the blanching. And then here's on the buccal. So 1 penetration, 1/2 to 1 full cartridge, and we have anesthesia of that full quadrant. Some people it will include the molars. Other people you might need to give a supplemental PSA, but that'll still get you down to 2 penetrations for an entire quadrant. In the technique, they talk about using a cotton swab to help put pressure on the needle tip right before you start. Just a quick tip. Just package up a bunch of cotton tips 2 at a time and just, have them sterilized, have them in your drawer with your wands so that you always have a sterile tip to place right against that sterile needle at the time of penetration. Then you don't end up with any issues around less than completely sterile cotton swabs. Here's the second episode with Dr. Tola that you might want to check out, and this one is Chairside Live, episode 80. And in this case, let's back up. In this case, we're doing a Gow Gates, and again, we do the entire injection with the wand, and you'll actually be able to hear the tones and things, but it'll give you step by step from start to finish on that Gow Gates injection. And the last little thing I just want to say in this area of techniques is these devices are incredibly portable. This is actually a small lunch cooler that obviously I got at REI. This device has traveled across the country with me numerous times. Definitely entertained some TSA guards at check-through stations. But if you do a lot of dentistry in the field, don't hesitate to pack this up and take it with you when you have electricity. It can go wherever you go. So my last portion here, and I think we'll get through this just fine, is looking at the ergonomics. And this is the other side of win-win. There's a lot of value in this for patients' comfort. And now I want to flip the table, and I want you to think about yourself. I want you to think about your hand, your thumb, your palm, your wrist at the end of the day, and how you are going to invest in the sustainability of your practice. And it's important to really note that clinicians are one of the most valuable assets in a practice. And if you're looking for sustainability, you need to look at sustainability of your wellness. And cumulative trauma, musculoskeletal disorders are something that everybody in dentistry needs to pay attention to, needs to be prepared to address, and the wand does that. I want you to just look at item 3. Keep wrists at a neutral angle. Just keep that in the back of your mind as you look at these next few pictures. So here we are. We saw this one before, and again, in all situations with a manual syringe, I am required to use flexion and exertion forces of my thumb and my palm to maneuver the syringe. Again, with my very small hand down here, I have to even be more extreme in the amount of flexion, more extreme in the extensions, and to close that gap initially is much greater force on my thumb here. With the wand, no flexion, no extension. Again, manual, flexion for every time you deposit, extension for every aspiration. The wand, no flexion, no extension. We actually measured this because I was really curious. So we got ourselves a trigger gauge and we wired it all up, and we actually measured these, and what we found is they were anywhere from 0.7 to 1 pound every time we went to aspirate. And when you think of doing multiple injections in a day, that adds up. 300 to 500 grams to deliver solution with a manual syringe. And for aspiration, excuse me here, I jumped over, 0 grams of pressure for either delivery or aspiration with a wand. Thumb extensions. This is giving a inferior alveolar injection. And you can see here we have that wrist, a lot of pull of the glove, extension here to get that aspiration, which will be followed by a flexion with enough pressure to move the stopper. With the wand, we have none of those forces in play. And just again to just reinforce, these are giving PSA injections. On the left, you can see that there's fairly neutral wrist, but look at the position of the thumb and how far that person's having to pull the thumb back. Exact same person, same patient, same injection, swapped out for the wand. Everything's relaxed, no requirement for flexion or extension. And last pair here, just looking at this, reaching across, again, PSA injections. So there really is an ergonomic advantage to using the wand. Because it's so light, we can manipulate around in many different positions we don't normally think of. It's easy to keep a neutral wrist, very light, so there's no weight we're having to carry. It doesn't require flexions or extensions in the thumb or the palm, and the net result clearly is an investment in sustainable clinical health. And I have one more. Again, this is just looking at an IA. In this picture on the right, you can see how close her fingers are to the hub. In this situation, to complete this injection, she's going to have to stop and move her hand back. So this is a really good example of that earlier discussion of where your grasp is, because in this case, she's not going to be able to get to depth. And in an experienced clinician, that's not going to really throw you, but when you're just getting used to it, that might throw you a little bit. So again, watch that you have a stopper's length back on that wand. And just keep in mind, each time you have a flexion or extension, that's just adding to cumulative trauma. So next steps, where do you go from here? So if you're just getting started, here's my challenge to you. I encourage you to commit yourself to 2 full weeks of doing every injection using your wand. I really believe the more you just commit yourself to the philosophy of the wand and start moving your muscle memories from manual extension and flexion techniques to very light neutral techniques with the wand, that it's just going to be very easy to just migrate and want to stay with that experience with the wand. My 6th grade teacher, Mrs. Syrie, always said, practice makes permanence. So take the time to pay attention to the details. Take your time to pay attention to doing it in a very skilled and healthful way so that your muscle memory is really there to benefit you, because it really pays to get this one right. Can never underestimate the learning curve. We just have to work with it. For those of you that may have had the device for a while and aren't getting the success that you want, it's really a matter of having to go back and just grow your confidence. Try it a few more times, get connected with somebody who's having successes, and find out how did they get there. One of the things I showed you was that use of the periodontal probe for figuring out your angles for those PDLs. That's for simple a technique. It's amazing the difference it can make in your success in single tooth anesthesia. Muscle memory, the longer you've been in practice, the more you kind of have to overcome and transition. Or if you're starting to have some musculoskeletal issues, this is actually the time that something's going to be there for you to help ease you through that. Really looking at practice sustainability, optimizing treatment time when we're able to do that single tooth in multiple quadrants, or just improve the patient experience of not having to leave numb. So here just, kind of what's in your C-Clad forecast, and just offering some resources, and I'll just leave these up here for you to kind of look at while I turn things back over to Danny, and if there's any questions. And the folks at Aseptico, they are the only dealers of this in North America, so they are the folks to contact. If you are wanting to get one or you have going to need some guidance, reach out to seasoned veterans. They are more than happy to talk about the wand and really share with you how they got to that point of great success. Again, the folks at Aseptico are really there to help. We succeeded teams, and Aseptico is really part of our team on this whole movement, to the wand, and so definitely reach up to them. And if you're disillusioned, just stick with it. It's going to come back and benefit, and you'll be glad that you did. And Danny, thank you. That's what I've got.
Oh, you're welcome. Thank you, Kathy. That was wonderful. And we're going to dive right into Q&A, but since you mentioned Aseptico, they are a great bunch of people. Just briefly, I became aware of them because, as some of you may know, I have a foundation called Climb for a Cause, and the Smile Tree, which is committed to funding and sustaining oral health education and treatment projects overseas. Aseptico carries a line of dental equipment, and not only did they make their equipment available for our projects, but Chris Berry, one of their key people, also has participated in a number of our climbing events. In fact, that kook just finished a little hike up the entire Pacific Crest Trail, which took him 4 months from Mexico to Canada. So he's no slouch, and they're very good people. That's actually how I connected with them, and it's a pleasure to offer them this opportunity to share this extremely valuable way to eliminate such a barrier to patients accepting treatment, which is just helping ensure their comfort. So thanks to you and to Aseptico. Let's dive into the questions. Now these came in, I'm reading them.
Really quickly, when you were talking about the portable equipment, one of the other things that Aseptico has been amazing in doing is they've actually provided their portable chairs that we've paired up with portable dental simulators to actually do hands-on courses at some of the different conventions that we've been to. So it's, they really are amazing in making opportunities happen for folks in training realm as well.
Yep, they have indeed. It's a pleasure working with them. I'm going to read these in the order they were received. Some of these questions may have been addressed in part or in whole, but I think it bears repeating anyway, because I think that everyone deserves to be sure that they're being heard. So the first question is, does the wand C-Clad system have pre-programmed flow rates built in for all of the various injection types?
Yes, it does. The flow rates are calibrated by the microprocessor to match up with the tissue compliance factors we saw in that earlier slide. And if we are prescribing to that 1 milliliter per minute rate or slower, then that STA mode gives us our rates for the palatal injections, the periodontal ligament injections, and that normal rate will give you a safe, acceptable rate for any other injection that you are going to deliver.
And you can even opt for cruise control if you want.
Yeah.
It's pretty much, yeah, it's like autopilot practically. Next question. Do you have or are you aware of any studies comparing patient comfort or team member ergonomic issues such as carpal tunnel syndrome, between the use of traditional versus C-Clad?
Specific to dentistry, no. But we've been pulling data from the ergonomic data for lab technicians that work with pipettes, and that is one of the most closely related to what we do. And we've just started to pose these questions ourselves and are actually very interested if other people run into data, because right now we're really just looking at this as at a curiosity level, and I very much would like to see some research on this.
Mm-hmm. How significant a factor are needle phobia, perceived pain, and anxiety in terms of patients seeking dental treatment and or canceling their appointments? This is sort of another, I think, study question.
I believe that the perception of pain, ranging from true needle phobias to situational anxiety, definitely keeps patients out of dental offices. and I've seen the wand in our environment, and as a school and a teaching clinic, we have essentially a public health clinic, and I have been amazed at the transitions of our patients. And because our students are slow, we see them numerous appointments, so we actually do get to see the progression from folks that are literally in tears at that first appointment to, after several experiences with the students and the C-Clads, just say, wow. And they were also amazed that in a public health type of situation, they were even allowed to have access to this kind of technology. So we've seen it.
Mm-hmm. I'm actually going in for my semi-annual recare appointment tomorrow, and I'm also having my final amalgam removed. And I'm not even giving a second thought to it because I know my dentist is up to speed on all this, and I don't even give it a second thought. And, you know, I just 3 screwdrivers before my breakfast meeting, and I'm fine. No, I'm just kidding.
Well, you'll see I have my own wand. I can take it to my appointments.
Well, there's the connection with oranges, you see. I just inject them with vodka instead of lidocaine. No, just kidding, folks. Now, this one was kind of addressed too, but what is the learning curve? In other words, this questioner wants to know how long does it take to master, and how frequently do practices buy, then never use the wand? It's a good question. I think you've implicitly addressed this by your emphasis, which is key, on the learning curve and practicing making permanence, I believe you said. And so, yeah, I wonder if you could address that further.
One of my observations, and I'd like to really stress for practicing clinicians, is look at everything you've accomplished to date, and in anything you decided you needed to learn or were going to learn, how you got there. And when we take students who have no experience whatsoever with anesthesia, and we start them on day 1, within a couple of injections, they've got it. They are, you know, routinely giving these injections in clinics to patients within 3 attempts, and that's with the limited experience they have in the middle of their dental hygiene training. And for example, our students have to take the REB, Regional Board Exam, in anesthesia, and I've had students who had only given injections with the manual syringe, and they wanted to, you know, pick up the C-Clad, and literally within 1 experience, because they knew the angles they needed, and then they just needed to modify how they're going to initiate the flow, how they're going to initiate the aspiration. And I just feel like if my students can get a hang of this within about 6 weeks' time, clinicians who are doing this every day and make the decision that they're going to do this, you're going to have it in just a matter of days to weeks.
I think that's right. I think there's a commitment required to trying something different, rewiring the muscle memory, as you talked about. There's almost an advantage in starting with a group of students who haven't used traditional injections, I imagine, because you have a more or less clean slate. But that said, I think I'm not a clinician, but I can see where just the different angles and the techniques that you've shown look like it's certainly a lot simpler to use.
For me personally, the first transition was how light it was.
Yes.
And I had to get used to the fact that it wasn't empty.
Right. You're actually doing something even though it doesn't feel like anything's happening.
Exactly.
Mm-hmm. I could see that. How do injections with the wand C-Clad device compare with a manual syringe in terms of post-op pain or tenderness at the injection site?
If we consider the relationship between flow rate and pressure, and we can accept the transfer of reduced pressure reduces trauma, that then is going to translate into less postoperative discomfort. And there was actually a presentation that I saw that actually was Dr. Mark Hockman, and it was a presentation actually on periodontal techniques and implants. And he was able to describe an observation that he's had where they actually were in a study club, so they had all these pictures up, and they realized that in his cases, nobody had this diffuse redness latent diffuse redness around these operative sites to the same degree that other folks that were using manual injections. And it's totally anecdotal, but again, it starts bringing up those questions. And this is all coming back to the relationship between flow and pressure, and there definitely are numerous studies out there that are looking at those factors, including a couple that were quoted on earlier slides.
Okay, and this question, can the single tooth procedure be used on the maxilla and lower molars?
Absolutely. Regardless of the site, we're taking advantage of that porosity of the cancellous bone. So any place that has a periodontal ligament, you could definitely use this technique.
Okay. And if I'm using carbocaine on a patient with a pre-existing heart condition, will using the wand STA adversely affect the duration or profundity of the anesthesia?
Interesting question. Let me kind of think that one a moment. My first response is yes, and it's in a positive manner. We're not differentiating. We're using carbocaine 3% or carbocaine 2% with levo. I'm assuming 3% because that's what we've got most readily available to us. And the use of the wand isn't going to change the behavior of a drug. So if that's an appropriate anesthetic choice for that individual, if anything, my take on it is it's going to improve the situation. If we lower the experience of pain, we also lower the stress on that patient. And if we've got a cardiac patient, lowering that stress is important. There's a lot of conversation that we don't need to withhold vasoconstrictor, again, because we want to make sure that we keep those patients out of a pain experience. But as far as the function altering the drug, not a relationship.
Gotcha. Fantastic. Kathy, I want to thank you again for delivering such a wonderful holiday present to me and to our attendees, and for allowing our registrants to learn more about how to remove such a significant barrier that keeps patients all too frequently from receiving the care they want, need, and deserve. In a few days, you will receive an email with instructions on how to receive your 1.5 hours of CE credit. And I want to now invite you to mark your calendars for our next webcast, which will be on Thursday, January 21st at 7 p.m. Central Time, when my next very special guest will be Dr. Kimberly Q. Hubinet, DDS MAGD, who will deliver a fascinating presentation entitled Remain Relevant, How Epigenetics and the Power of NRF2 Will Revolutionize the Way You Deliver Optimum Health to Your Patients. Until then, this is Danny Bobrow, again with special thanks to Kathy and Aseptico, and thanking you for your commitment, your continuing commitment to practice perfection. Thanks again, Kathy, and goodbye, everybody.
Thank you, Danny.